Welcome to the Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, the Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper and Dr. Robert Graper, also known as the Doc Dudes.
All right, welcome to another episode of the Doc Dudes. Dr. Bob Graper.
Hello.
And I'm Garrett Harper, and today's topic is going to be fun. For guys and girls.
Oh, yeah.
For guys and girls, right?
Everybody likes pretty breasts.
That's exactly right.
Really everybody.
That's exactly right. So we are going to specifically talk today about breast augmentations. Breast augmentations mean implants, right? So we'll talk about implants. Yeah. We'll talk about choices of implants. We'll talk about what we like.
A t-shirt.
That's right, a t-shirt. And we'll try to just kind of go over everything so that people feel like they're better educated about why we kind of have our philosophy and what implants we typically try to steer our patients to. We steer because one of the things that you and I both say is we are not the breast police.
What does that mean? I want to have double Ds. What do you mean I can't have double Ds?
I think Sharon would be mad first.
Yeah, if I had double Ds?
If you had double Ds.
Upstager?
She just would not be happy with a husband that has double Ds. I think...
So you go with a modest Phil Mickelson B to C minus?
That guy's lost a lot of weight. He looks a lot better now.
Zipic.
Yes. Oh, that's right. It does all those things. But what we mean by that is, of course, you and I, every person in the world has their opinion of what characteristics make a beautiful breast, right? But ultimately, the patient steers the ship.
Boss.
Steers the ship. Now, there's a huge caveat to that.
How much guidance?
That's a great question. Because what I tell patients that come in for breast augmentation is I don't want to do anything that I'm pretty sure is going to be a problem down the road.
Exactly. You don't want to create another surgery or a durability problem.
You don't. And part of it is because they are evaluating us. They are interviewing us to see if they want us to be their plastic surgeon. But we're also kind of interviewing them to see if we want them as our patient, right?
Us.
That's exactly right. And so I really hate complications. There's not a plastic surgeon in the world that doesn't have them. We do not have control over every single thing in the world, but what we can do through our experience and through what we have learned, and in some instances taught ourselves, we've figured out what can cause problems, right? And so...
let's avoid those.
Avoid
patients avoid them.
That's right.
What's a typical patient look like?
Well, that's a great question. So it's typically two patients, right? It's somebody who is either born small-chested or smaller-chested than they feel is beautiful, or it's somebody who's had kids.
And lost it.
And their breasts have changed. And
or maybe liked it when they were bigger,
right,
pregnant,
right,
and went
right,
away. Or it atrophied and they're smaller than they were to begin with.
100%. And so those are traditionally the two patients that come in for a standard breast augmentation, not a implant exchange or something like that. But it's someone who, at any age, I mean, I've had 60-year-old women. So I've had women who, and that's one thing that they say, oh, I wish I'd have done this 30 years ago. And I'm like, oh man, I mean, I'm glad you're doing it now, but wow, I wish you would have too, because who knows?
The confidence level
is absolutely. I think it's critical.
Maybe it shouldn't be that way, but it is.
Right. But those are, I mean, we're in a breast-obsessed culture. So, I mean, I understand that. It really is. And so, thankfully now, I think there's less of the Baywatch looking kind of fake,
unnatural.
Unnatural looking. And I think
some people still like that. And when they come in and they want the fake look, how do you counsel them?
I counseled them that I am not the breast police, but that while there are different looks that I think are acceptable, and I'm willing to be someone's partner and their plastic surgeon in this journey, I certainly tell them first and foremost that there are some implants that will not fit your body, that are only going to cause problems. And so we take a bunch of measurements. And when we take a series of measurements in patients, the most critical measurement is their base width, which is basically the width of their breast.
Is that the width that they present with or the width that they'd like to be?
So this is like chest wall. I mean, I'm looking at, if we talk about rib cages and sternums and things like that, I'm looking at where a breast would lie on their chest to where they have
centered under the nipple,
roundness to where the lateral aspect of their breast, or the side boob, that's such a technical term, has a little bit of silhouette off of their, ribs, and that they have cleavage. That's typically what patients want, right?
Can all people have cleavage?
All patients can have some cleavage, and I think by implant choice and implant placement choice, we improve our chances of getting that desired cleavage. But yeah, there's the occasional patient where I have to point out to them, look at how wide your sternum is. This
or
is
how
just
wide your
body.
Nipples are.
Right. And so those are all things that
Tell
you have
them why
to take
the
into
wide nipple
consideration.
matters.
And so there is a perfect kind of placement of the nipple on the breast. I mean, traditionally speaking, if we're going straight down the breast mound, right, the breast shape, you want that nipple areolar complex to be just lateral to that. If it's medial to that, which can happen in congenital cases, patients that have restrictive breasts. I had one last week. One breast was perfect, and the other one, because of skeletal wall abnormalities and just kind of developmental issues.
Like a Poland?
Yeah, kind of. I mean, she had a pec muscle, so she wasn't a true Poland. It's more like a pectus. And a pectus is where you look at your sternum, where you look at your chest plate, and you feel like you could, put a golf ball in there, right? Or sometimes
rain gauge.
Yeah, or sometimes that's right. Sometimes the ribs are like turned in, right? Like you should kind of have this
a tequila
convexity to it, right? Tequila, that's good. Yeah, that happens. Forget about the belly button. Let's just put it right in the pectus. That's exactly right. And you got to worry about that. And you got to tell the patient, like, look, the left breast is going to be absolutely beautifully gorgeous by every single perspective. The right breast, we're trying to help you get a better shape and get a better volume so that things are kind of set up. And for this patient, I actually had to go against what I normally always do, which is I try to be consistent with what implant I'm putting on each side. And on this one, I couldn't because of the chest wall abnormalities. I had to go up 2 different profiles on the sunken side so that when she lay down, she would have the same projection. And that's one thing. So if you put the same implant on 2 very different breasts, you're still going to get very different breasts, right? So there are the occasions where we have to make changes for patients and we have to make adjustments with what implant, because these implants come in so many different widths and profiles, right? So tell us a little bit about like width and profile. I mean, there's 200 different implants with one of the companies. I mean, how do you choose? How do you narrow it down?
Well, you and I trained in different eras. And so for my training, we were simpler than you, and we looked at a patient's existing anatomy, how big her natural breast was, what her goals were, and we would put in whatever size implant would get her to those goals, assuming she had enough skin envelope to get our incision closed and wasn't just, so tight, so fake. We've all seen that. Now, tell us your training and how you do with the base width, and does that limit you in some patients when their base width won't let them get to the size they want to be? How do you handle that?
Oh, absolutely. Certainly the size of their implant. I mean, a lot of women come in with, they've talked to their friends. They love their friend's breast. And they said, my friend got a 450 cc high profile implant. That's what I want. And I'm like, your friend's way different than you. Your friend's body's different. Your friend's breasts were different to begin with. So I am what I think most people refer to as a biodimensional breast surgeon. And so I'm going to take a series of measurements, and it's not just to put them in the computer and never look at them again. It's to help me decide what implants are going to look the best and the safest. So that base width measurement that we talked about, that's kind of their hemi chest. That is, if you had a perfect breast here, how wide would that be? We measure it in centimeters, right? Which is kind of strange because we're the only country that typically doesn't measure in centimeters, but we do in this case. And then I'm willing to choose an implant that's either a 0.5 centimeter wider than that, if you need the implant to kind of give you that side boob kind of curvature.
A half centimeter on inside and outside, or just total?
Just total. And so if I measure somebody out to be a 12.5 centimeter base width, which is about the average width of a chest on a 5'6", 5'7", 130, 145 pound woman. And so if they need the implant to do some good work shaping out the lateral aspect of their breast, I may use a slightly wider implant than their base width. I may jump up to a 13. But if they don't need that, and that extra width is only gonna broaden their chest and make them look wider, which is not typically the direction most women want to go with their figure, then I'll go with a half a centimeter narrower.
But that's all.
But that's it. So if somebody's a 12.5, I say we can look at implants that are 12 centimeters to 13 centimeters in width. I mean, there are crazy exceptions to that, but this is just the general standard. And then for each one of those widths, we have 5 different profiles. And so what I tell patients is a profile of an implant is how it looks from the side. It's like a stack of pancakes, right? You go to IHOP with your kid, and every pancake's the exact same size. And if they stack them perfectly, if you're above the table looking down, you don't know which one has 1, 2, 3, 4, or 5 pancakes on it. It's when you look at it from the side. And so that's the same thing with the profile of these implants. Nice pancakes, right? Really good pancakes. Syrup, everything, butter. It's just great. So in any event, that's what I tell them about the profile. And so that's where we can add volume on the front of the implant, that projection area, to get them to a cup size that they may really desire. Now, if somebody says, I'm an A cup, I don't have any laxity in my skin, I mean, it's tight as a tick, but I want to be a double D, it's not going to happen. It's just not going to. Not necessarily not ever, but it may take several surgeries.
Sort of an expander type.
Yeah, almost. I mean, I've seen it where people have in the past, when somebody wants to go that big, they've almost treated it like an expander, and they've even placed expanders, which is something that we use in breast reconstruction. But no, I tell a patient, we're going to do the dissection, and your breast envelope, your skin envelope, however tight your skin is, we've got to close it.
It's part of your anatomy and limiting factors.
Yeah, we've got to close it, and that's one of those things. But if your skin accommodates, if your breast tissue stretches out, if you then get some more room to place a larger implant in the future, then you can do that. But you've got to be safe, and you've got to be smart with the decisions that you're making. So I think by sticking to biodimensionally, sticking to their measurements and helping guide them into making smart decisions, I rarely have had a patient that's come back that's taken me up on that, right? That hasn't loved their breasts after we've kind of done it. I think
it works. That system works.
Well, I think some of it's the opposite of what we see in breast reduction patients. I think sometimes breast reduction patients come in, they have large breasts, and they just say, I want them off. I want to be an A cup. And you're like,
no, you don't.
Ma'am, no, you do not. Like, you are frustrated. The grass is always greener. You've got large breasts that have gotten in the way, that are dragging you down, literally giving you neck pain and back pain. But let's go to a place that's going to be perfect for your figure, perfect for your body, and let's let you live there for a little while and see what you think.
And your lifestyle.
100%.
How does a lifestyle affect an implant choice or position above or below the muscle?
So it used to really affect it. I mean, if somebody came in and was extremely fit, athletic, always working out, doing stuff, implants underneath their pec muscle were kind of disruptive, and almost looked weirder to have this, big stocky, like any of the
back in the day. Yeah, but back in the day when we didn't have as good implants, that's kind of, we just said you had to put up with it.
Oh, 100%.
Now,
100%. But now the newer devices, these gummy bear devices, and I hate that term. It was coined by a guy out in California, but it is a good way to help.
It was Tebbets. It wasn't Tebbets?
No, I think it was Grant Stevens.
Okay.
Anyways, I do tell patients, the older generation implants, if you cut an implant in half, you just opened it, took it out of the box, took a samurai sword to it, it's going to ooze out like honey, molasses. And that's kind of gross, right? I mean,
It's certainly, after they've been in there for 20 years and
Yeah.
you're trying to take one out, it's a goo ball mess.
it's a goo ball mess. And so the newer devices, you cut them in half with that same samurai sword, nothing oozes out. It's like the inside of a gummy bear, but a really soft,
delicious.
chewable, delicious, straight off the conveyor belt Haribo or Black Forest gummy bear. These are not the white gummy bears that are like from last
Not one
year's
stuck.
Halloween's. No ones that are stuck in between the car seats or anything like that. So they don't ooze. So they're safer. They maintain their form. And these implants do really well above the muscle. So whereas you used to 5 years ago, I was 95%, all of my implants were below the muscle.
Me too. And you changed that for me.
Now I'm 95% above.
Well, you started using them in your reconstructions
Correct.
that don't have any breast
Correct.
tissue on top.
All
because
their
of
breast
the
tissue's been
mastectomy.
taken away.
So
That's
if it
exactly
works with that,
Right.
that's what really got my attention,
Yep.
and you did that.
Yep. And so, obviously the technology has kind of changed. And there's still people to this day who will tell you, absolutely not. I'm putting every implant underneath the muscle. And that's not the right answer.
Well, and we used to worry that that firmness rate, that capsular contracture rate, was better under the muscle, and I think it's been shown that that isn't the case.
Well, it may have been when we were using saline devices. I haven't put a saline breast implant in a patient in 10 years. And I just don't. And I know that they're on the market, and I know patients come in, but by the time we educate them
why would you?
on the safety, why would you ever use it? I mean, both the saline device and the silicone gel device have a silicone gel shell that substance sits in. And with less capsular contracture rate, with a more natural feel, with a more natural look, without the water hammering effect of every time you're running or jumping up and down, that water's banging around inside the implant. It's just a overall better situation. And just like I don't let a patient choose a size or a profile that won't be safe and do well, I just tell patients, if you want a saline implant, I'm not your guy.
Well, it's an inferior result.
It is.
So what about patients who are thinking about having kids or have kids and breastfeeding? What are the issues there? What do you discuss?
So there's no issues. So in either event, unless you're placing the incision around the areola, which I don't do. Bad idea. So, we used to try to find, well, how can we hide the incision? Let's go in the armpit. Nobody does that anymore.
That was a Tebbets.
That was a Tebbets. Let's go through the
Not every idea is a good idea.
Right. Let's go through the belly button.
Boom.
I mean, terrible, right? And so a lot of the patients that had those, they may have looked great initially, but we've
And ended up too high.
Right. And we've certainly evolved to the point where we've realized that you got to divide some of the muscle in order to get good expansion of the lower pole and roundness of the lower pole, and let the implant get to the place in the pocket where it creates the most beautiful shaped breast. And so now we don't have to worry about that because we put the whole thing above the muscle. So nothing's holding it up. It's able to have, complete autonomy inside the pocket, and whatever implant you choose is the shape that the breast is going to be. So we've really been able to use the implants nicely. In no case, if we're using an incision that's in the inframammary fold, are we detaching any of the ducts or glands that allow for breastfeeding. We're not cutting any of them.
You're not. Yeah,
We're not getting in the way. So
even though you're near it, you're not cutting any.
Correct.
And the scar heals great.
It's a 2-inch incision that's in the fold of their breast, where the breast kind of comes off the chest. You never see it. It looks beautiful. But, for the 20-year-old that thinks she's going to have kids, I mean, it's perfectly safe for you to have these.
Yeah.
And so, what I tell patients is, and that was part of the conundrum, and I think some of the ambiguity when patients would come and say, well, don't I have to have implants replaced every 10 years? I'm like, no. I mean, statistically, they looked at all comers, right? And they said, well, at what point do a quarter of patients have a second cosmetic breast procedure after their augmentation? And that was like at 10 years.
Yeah, the number I create is at 15 years, half of them are great. They don't want anything different. And the other half have done something. And that something most frequently is they loved them and they made them bigger.
Right. But think about what happens to a woman's breast. If the average age of an implant's 25 years old, think of what happens between the ages of 25 to 35 to a woman's breast if they have kids, right? If there's fluctuations in weight and things like that. So the second breast surgery, it's not always the implant's fault, right? Sure. That's what we have to kind of extrapolate out and see, well, how long do these implants last? I tell patients there's no shelf life. There's no half-life. Like, by all intents and purposes, you could have this done and take these to the nursing home with you.
How old was your longest implant patient? Meaning, how long had an implant been in the longest in your experience?
Well, so I've had implants that I've taken out that were 40 years old. Yeah. I mean, these were people who went to Houston.
Yes.
And had the first set of implant. That's right.
I had a lady who had an implant placed when Kennedy was president.
Wow.
Yeah, it was like 45 years, and they were awful.
Oh, awful. But total different technology. These things were like first
and
generation.
We made them better.
And they're
How about the longest implant that was just fine, looked great, felt great?
I've been surprised sometimes, right? Because every time somebody comes to me with soft breasts where they had implants placed 40 years ago, I'm 100% convinced that it's ruptured. Yeah. And so why it's soft is because you don't even have a formable implant in there. You've got gel that's just sitting inside your pocket.
Which wouldn't happen with a new implant.
Correct, exactly. And that's the point of the new implants. And then I've gone in there and the implant's fine.
Yeah.
And I'm like, wow.
Mine was 33 years. And usually I say, well, if you're going to be in the operating room, you ought to fix these.
Right.
Because they could rupture any time.
Right.
But she wasn't going to be in the operating room for any reason. And they were 33 years old and they looked and felt great. I mean, well, okay.
Yeah. Leave them alone.
Keep us posted.
That's exactly right. Leave them alone. Just, thank your stars and carry on. Yeah, exactly.
And part of that was she didn't go a size too big. Don't you think the bigger patients go, the less durable, the pretty result?
100%, right? The third law of thermodynamics. For every action, there's an equal and opposite reaction. So I think the more you stress your body with the weight and size of an implant, the more your body's going to respond to it. I mean, we want this kind of symbiotic relationship between your body and the implant that we choose. And so that's where I start when I'm talking to my patients and trying to get a feel. I ask every patient to provide wish pics, right? I mean, we're visual learners. And so I don't want to talk about bra size because they can go to 5 different places and get 5 different measurements. So I say, okay, don't worry about cup size. Don't worry about, some people think their number's going to change on the bra. So I'm like, okay, well, you have zero idea of how bras are done. So show me. I want to know the characteristics, and it doesn't have to be somebody that has your same six-pack. I'm just looking at breasts. I'm looking at proportions. I'm looking at, okay, she likes a little bit more side boob. She likes a little more cleavage. She likes a little bit more fullness, a little more projection. She likes a little less natural look or a more natural look. All that gets shown to us through pictures so much better than somebody just kind of telling us. So I ask for those pictures, and if somebody just is wildly...
I was going to say, how about realistic expectations?
Right. If I feel, and I've had that recently, I had somebody who was talking about an implant that they wanted, and I said, this is what I'm willing to do because I think that's going to cause problems. And they were signed up for surgery, and then they came back and they wanted to rediscuss and say, like, look, I'm really worried you're not going to get me as big as I want to be. Boom. And I high-fived them, shook their hand, and I said, there's other plastic surgeons. I promise. I hope you'll think about it. And I hope you don't do this because I do think it'll... And maybe that patient does fantastic and is great, and I was wrong. But I've done enough. We've done enough to where we know when we're kind of putting our patient in harm's way. And there's no reason this is cosmetic. This is elective. This is surgery to make your life better.
I got one question because I know we're getting short on time. How about lifts at the same time as implants? What are your feelings?
I think it's great. I think it depends a little on the patient, right? But if the patient's breast envelope can take a volume change and can take a lift at the same time. I prefer to do them at the same time. I just think that if you separate them, you're 100% going to have two surgeries.
Exactly.
And if you do them at the same time, let's say 10% of patients go back and you need to tighten their breast envelope a little bit. They stretch out a little bit and you need to tighten them.
And what is that typically a postpartum patient? Is that a massive weight loss patient?
So those are great patients because once things have already been stretched out and kind of retracted and came back, I think the skin is more apt to stretch in again, right? But if you overcorrect them with anticipation that somebody's going to stretch out, like, I know it looks funny now, but it'll stretch out to perfect, right? It may, but if it doesn't, you're hosed.
And if it does, it's a minor touch-up.
Right, that's exactly right. And so, I like for things to look as close to perfect on the table as possible when I'm finishing. I understand that there are sometimes I'll over tighten them a little bit with anticipation of that, but it's not these like upside down looking breasts where it looks like a Doberman pincher.
Flat on the bottom and round on top.
It's just horrendous. And you would see those with the lollipop incisions sometimes. And the hand holding for the patient that this will look better at 3 months. And then it didn't. And then you're like, well, it'll be better at 6 months. And then it's, who wants to walk around with ugly breasts for 6 months? Nobody, not any of my patients. So I think it's a safe procedure. I think it's a great procedure. Occasionally, you'll have a patient that kind of has almost a constrictive style breast where I'll do an implant first and I'll say, like, let's kind of see how this stretches out because you can't physically put an implant in and lift them at the same time and get it closed. You just can't do it. And so about half the time those patients love their breasts after just the augmentation and say, I'm all right that my nipple's not in a perfect spot. I love my breasts now. And then half of them come back and they're like, yeah, I'm ready for the lift. And
so you find that using an implant on top of the muscle will negate the need for a lift in some patients?
Yeah, some patients. But I mean, you got to look at the quality of their tissues, right? The distance from somebody's neck, their sternal notch, right at the base of their neck to their nipple can increase if you've got an implant above the muscle because you no longer have the muscle holding on in the upper pole of the breast, holding on to that tissue. So it can stretch out. But conversely,
it can stretch out the bottom.
It can stretch out the bottom. And so if a patient has good skin quality, doesn't have stretch marks, and is going with a appropriately sized and profiled device for them, oh man, a 2-inch incision in the fold with one of the brand new cohesive devices placed above the muscle is absolutely fantastic. And
the recovery much better than under the muscle?
A lot easier, less chances of pulling a muscle, which can pull a blood vessel along with it and causing some problems. But, patients are using their arms immediately. I mean, this really is it's a different ball game. It is. It's a game changer. And I think we've seen that started in reconstruction and then has certainly parlayed itself as the technology has now been available cosmetically and has certainly just made the whole experience a lot better.
Well, I hope this has been very helpful for our listeners. Yeah. It's certainly a great operation that you do a lot of. Any final thoughts?
No, I just think that, patients need to come with an idea in mind of what they want to look like, and they need to realize photos are great, and they need to realize that, our recommendations are that for a reason, not because we think we're the breast police and every breast needs to look the exact same, because they don't.
They all need to look pretty.
They all need to look pretty, and they all need to safely look pretty for as long as possible.
Excellent.
So, well, thank you very much. If you've got questions or topics you'd like us to cover, visit our website at www.ghsurgery.com. Click on the Doc Dudes from the homepage, and you'll find a link to click to submit your questions and ideas. You can also listen to all of the Doc Dudes episodes on our website, as well as Apple, Spotify, YouTube, or anywhere you care to listen to your favorite podcasts. Remember to follow us on Instagram and Facebook to find out when new episodes drop and other information about our practice. But signing out after another Doc Dudes. I am Garrett Harper.
Robert Graper.
And we will see you guys later.
Later.